my name is Babak Jeremy. I'm a cerebrovascular/endovascular neurosurgeon with Northwestern Medicine, and I am showing you our newest hybrid biplane neurosurgical operating room. This is really the culmination of many years of work, because fundamentally we want to bring these two technologies together so they allow us to do things we could not do before with separate teams in separate areas. It allows us to have the safety of an open surgical procedure with endovascular backup or an endovascular procedure with open surgical backup. And fundamentally, it allows us to shorten and combine procedures in a room that really is the largest, most modern image-guided neurosurgical room we've had. We think that's going to be better for patient outcomes. We believe that by having simultaneous access to image-guided procedures and open surgical procedures, we'll have less complications, and if we do, we can manage it more effectively. And we believe that instead of having different procedures at different times in different rooms, we can combine them, being able to offer a more effective one-stop shop for patients who have spine, cerebrovascular, or functional disease. So we can think of a couple of examples over the past few months which would showcase how this room has really made us provide better care. A simple example would be a craniotomy for a supraorbital, minimally invasive approach to clip an anterior communicating artery aneurysm. This is a procedure where under the microscope and with Doppler ultrasound and even fluorescein angiography, things look great, but we're able to now go one step further, and before closing the craniotomy, we can immediately obtain a high-resolution biplane image as well as a 3D DSA of our clip construct. And that demonstrated to us that what we were not able to see is our clips had actually narrowed down one of the blood vessels and restricted blood flow. And so instead of discovering this the next day or in a future angiogram and risking a potential future stroke, we're able to adjust that clip to perfection with the highest resolution angiography at the time of craniotomy, making sure that the patient leaves the operating room with a perfect construct. Another example would then build upon that. It's not just a safety check of one procedure versus the other. We can now combine procedures. So we have had patients who come in emergently with a brain hemorrhage. It's unclear if there's an underlying vascular malformation or not. We're now able in the same room to do a very quick diagnostic angiogram, know what we're getting into, and then rapidly transition to a craniotomy for evacuation of that hemorrhage and or dealing with any vascular malformation that's on the way. That's an example of an emergent procedure. Going in next up, there are patients who have elective vascular malformations. In the past, we would need to perhaps embolize these for multiple sessions, then come to a craniotomy. We can now do a much more aggressive embolization in the same anesthetic, knowing that immediately we're going to proceed to a craniotomy. And so not only can we more aggressively embolize these patients, we don't have the risk of post-embolization hemorrhage, because immediately after, we're going to go to the craniotomy and resect that entire malformation. And then sometimes there aren't transarterial or transvenous direct routes to vascular malformation. Here, in the operating room, we can actually provide surgical approaches, be it, let's say, through an eyebrow incision or a small burr hole with a craniotomy to access an occluded sinus, or even percutaneous carotid access. If that's not safe, we can do open carotid access and so on. We can combine the open surgical access methods for an endovascular procedure. Again, bringing the best of the technologies and the best of two teams together to work as one in one room under one anesthetic for better outcomes.